let's chat a little bit about two emerging therapies. The first of these is crisaborole, as mentioned, a new topical for mild to moderate atopic dermatitis. Crisaborole is the first of the phosphodiesterase 4 inhibitors. And phosphodiesterase 4 inhibition works by increasing cyclic AMP and thereby decreasing the release of pro-inflammatory cytokines. And it was approved by the FDA in December of 2016. There have been several studies supporting its use, including two tandem phase 3 studies that were double-blind and vehicle-controlled. These were performed in patients 2 years of age through adulthood with atopic dermatitis who had at least 5% body surface area and a score of mild to moderate. These patients had to be off of their topicals for at least 2 weeks, and any kind of systemic therapy had to have stopped at least 4 weeks earlier. The medication was applied twice daily to lesional skin, excluding the scalp, and was done for 28 days. And in these studies, in both groups, there was a statistically significant difference between those who were treated with the crisaborole and those who were treated with the vehicle. Now, interestingly, but not uncommonly, in both of these studies, there was a very high vehicle response rate, and that tells you that it's a good vehicle as well,
right,
but also is pretty typical with what we've seen in atopic dermatitis studies, where just enrollment in a trial with vehicle alone does lead to improvement in a certain percentage that can be a pretty high percentage, particularly in those with mild to moderate disease. I will add that in this study there were individual features of atopic dermatitis that were also looked at: the erythema, the exudation, excoriation, induration and papulation, and lichenification. And in each of those sets as well, there was a statistically significant difference between those who had the crisaborole versus those who were using placebo. Now, we can consider an adult who has severe atopic dermatitis, Tamika, a 32-year-old, who first developed it at 23 years of age. And she's been treated with intensive topical therapy as well as systemic medication. She's either gotten adverse effects or she's just not responded. She's been treated with cyclosporin, mycophenolate mofetil, methotrexate. She really couldn't comply with phototherapy. So she's been on this constant use of topical corticosteroid. When you try to get her to proactive therapy with a few times a week, she's just flared terribly. She's got poor quality of life. She doesn't sleep well. She's a school teacher. It's very hard for her to function.
Yeah, I mean, there are obviously unmet needs for managing such patients, and particularly adult patients who really present with very severe atopic dermatitis, who really seem to be refractory to topical therapy, and even, as you mentioned, systemic drugs that we're familiar with. So we really need new agents to address this unique population. Dupilumab is a monoclonal antibody that specifically blocks the IL-4 receptor alpha, which then would block the stimulation of that receptor by IL-13 and IL-4. So it blocks the effects of IL-13 and IL-4, which are Th2 cytokines, which are very, very important in the pro-inflammatory Th2-directed cascade that we know occurs in atopic dermatitis. This is a new agent that will be administered through subcutaneous injection. So I'm going to discuss an early phase 2 trial, which was done in patients with moderate to severe atopic dermatitis, and these patients had inadequate response to topical treatment, topical corticosteroids or calcineurin inhibitors. The study was done, this phase 2 study was done by randomizing patients 1 to 1 to 1 to 1 to 1 equally to several arms. Dupilumab administered on a weekly basis, Dupilumab administered 300 milligrams every 2 weeks, 200 milligrams every 2 weeks, as you can see, 300 milligrams every 4 weeks, or 100 milligrams every 4 weeks, and a placebo arm was also included in this study, and the treatment period was for 16 weeks. So this is some of the data that emerged from this early study, and this is a phase 2 dose-ranging study. And as you can see, this shows data in terms of what happened during the course of treatment, the change from baseline over the first 8 weeks in the severity index, the Eczema Area Severity Index, or EASI, which is a standard index that's used in many of these clinical trials to determine eczema severity. And we can see there was clearly a dose response reduction in this index, indicating improvement in atopic dermatitis, particularly in the patients that received, and you can see the final 2 blocks on the right, those that received the 300 milligram dose on a weekly basis, and those that received a 300 milligram dose every 2 weeks had nearly an equivalent of response ranging between 65 and 75% reduction in this EASI score index. So the results of this study demonstrated improvement in the EASI score, and this was significantly greater than that was observed in the placebo. So all doses actually showed improvement, but the greatest improvement, as you can see from the data, was in the 300 milligram dose administered weekly or every other week. The treatment emergent adverse effects, which were, of course, evaluated in this clinical trial, seem to be equivalent in terms of those reported by patients on active Dupilumab or placebo. So that didn't seem to be any really signals in terms of safety issues related to therapy.
And there have been some phase 3 trials too, of course. This drug is called Solo 1 and Solo 2, 2 separate but in parallel phase 3 double-blind clinical trials. These trials were, again, just in adults with chronic moderate to severe atopic dermatitis that was inadequately controlled by topical treatment, or for whom topical treatment was inadvisable. They had to have an investigator global assessment score of 3, or moderate, or 4, severe. And they were randomized to either that every other week 300 milligrams of Dupilumab or to Dupilumab 300 milligrams every week or placebo. And the Dupilumab group received 600 milligram loading dosage. Now these individuals were able to get moisturizers twice daily for the 7-day run-in before randomization and then throughout the trial. And they were allowed to have topical or even systemic rescue therapy. If systemic rescue treatment, they were discontinued, but otherwise they were allowed to continue in the trial with the topical. And with this trial, once again, saw a huge difference between those on placebo and those who were treated with Dupilumab. Very similar results in these parallel trials. Interestingly, in the trials, the every other week 300 milligram did just as well. And of course, there will be patients who really require the weekly dose, but this suggests to us that for maintenance, it will probably be likely that these patients can come down to an every other week dosing. There were secondary endpoints as well, including patients with an EASI 75, so that reduction by 75% at week 16, the endpoint in that. Similarly, also showed an excellent separation between those on placebo and those treated with the active Dupilumab. And in this case, 50% in Solo 1 and almost 50% in Solo 2 achieved that very high goal of 75% reduction within that 16-week period. So highly effective medication and the first biologic that's come out. In these studies, there was significantly greater improvement in itch, in sleep, in the symptoms of anxiety or depression, and overall quality of life. And as you might expect, fewer patients ended up using rescue medications when they were treated with Dupilumab, and that was only 19% versus 52% who chose to use them at some point on the placebo.
In terms of adverse effects of these trials, these are listed in this table here, and the only one that really stood out was the allergic conjunctivitis or conjunctivitis And as you can see that this was notable in the treated, Dupilumab-treated groups versus the placebo. The reason or explanation for this is unclear. Suffice it to say there was a very low incidence of this effect. But this will be looked at, I guess, in the future.
Absolutely. I want to mention, too, that Dupilumab is just the tip of the iceberg here.
Right.
We're really excited
Right.
about it being available. It's going to make a huge difference in our treatment
Absolutely.
regimen.
Yeah.
But because we understand the pathophysiology, as we talked about earlier, there are other potential targets, and they are being very vigorously looked at in phase 1 and phase 2 trials, advancing towards phase 3 trials. For example, Dupilumab, of course, as mentioned, is the interleukin-4 receptor, but interleukin 13, which is the ligand for that receptor, is being vigorously looked at, as well as some other cytokines that we know are increased, particularly interleukin 31 as a potential anti-itch agent. There are JAK kinase inhibitors, the Janus kinase inhibitors, which are looking promising in case reports and are undergoing trials now. And agents, for example, blocking thymic stromal lymphopoietin, which we know is increased as an early component of that Th2 cascade. Histamine 4 receptor blockers looking interesting, and even liver X receptor agonists, or LXR agonists, coming on the market, as well as more studies, as mentioned earlier, on phosphodiesterase 4 inhibition. So we've got a lot of hope now, for the first time, for these individuals with atopic dermatitis for new products.
And some of these are small molecules, not necessarily monoclonal antibodies that you need to inject, and some may be available, if they're effective, as oral formulations.
Right. The JAK inhibitors, the
Yeah.
H4 receptor blockers, for example, are going to be oral agents.
Yeah, very exciting.